statins. And before we get into the video, I'm already hearing, oh my gosh, big pharma shill. Actually, I'm probably more of a big wellness shill because I've been on the scientific advisory committee for two different supplement companies, and big supplement companies help formulate supplements, talk about supplements all the time, recommend supplements. So yeah. And if you look at my open CMS payments, which, as a physician, payments from pharma have to be disclosed, unlike your favorite wellness influencer and their commissions, you'll see some food and beverage commissions. So what does that mean? Did pharmaceutical reps take me out to dinner? No, I used to go to these things for CE. That got reported as food and beverage. However, in the urgent care job I work sometimes, if a pharma rep comes by and brings lunch and I'm there, that gets reported as me taking payments, even though I don't eat the lunch. I always bring my lunch. So that's my funding. My three biggest problems with statin therapy, and I do have problems with statin therapy. Number one, when people use a trial of statins for primary prevention without lifestyle interventions first. I usually give people a 3 to 6 month window. Show me that you can improve this, depending on their risk factors and so on and so forth. And if they don't, then we're talking about medication. And I tend to use PCSK9 inhibitors more now than statins. Number two is dosing. I think most of the time these things are way overdosed. For example, with rosuvastatin, which I use a lot, I don't go more than 10 milligrams. You get like 80% of the effect at 10 milligrams. So going higher than that, I'm not getting much effect for an increased risk of possible adverse effects. And then number three is not taking patients' concerns about adverse effects seriously. I've seen this in social media videos. I've seen this in talking to patients where the doctor didn't take that patient's concern seriously. And the myalgias are real. In fact, about 1 in 15 people in the first year will experience myalgias. However, discontinuation rates in trials between statins and placebos are about the same at about 0.6%. So take that how you will. Diabetes risk is real, but it's small. And the excess risk is between 0.1 to 1.3% per year. And it's typically in people who are either already pre-diabetic or they have significant risk factors for developing diabetes. And if you look at the A1C bump, it's less than 0.1% on average. So what are we talking about today? The whole purpose of this video is to talk about post-marketing surveillance in that process. I'm a licensed pharmacist, so these are things that we've been taught in pharmacy school. This is kind of stuff I pay attention to, not only as a pharmacist, but because I'm a pharmacist who's an internal medicine physician. Now, statins are probably public enemy number one when it comes to medications. The appropriate use of statins saves lives. I've talked about statins in my book. 2022 meta-analysis found a composite CV outcome with an absolute risk reduction of 1.3%. Now, the issue here is the risk reduction is not as high, and this is for primary prevention, it's not as high as you have been led to believe, which is why in my book I talk about don't just take medication, do the lifestyle stuff too. The number needed to treat here is about 78 people, so take that for as you will. But this is more about the process of post-marketing surveillance, which can affect product labeling. So things like depression, impaired cognitive effects, sleep disturbances, other potential adverse effects have been added to labeling in certain countries based upon post-marketing surveillance. But do these actually appear in the randomized controlled trials? Because what happens in post-marketing surveillance is people on a certain medication, something happens, and this gets reported to saying, hey, your person was on this and this happened. But that does not inform causality, right? The randomized controlled trials are the things that we use to determine causality. And this study used data from the cholesterol treatment Trialists collaboration. And before you ask who funds this, it's funded by the British Heart Foundation, UK Medical Research Council, and the Australian National Health and Medical Research Council. That's who funds this group. Now, the individual authors, some of them have received grants from the pharmaceutical industry. Take that for what you will. To me, that doesn't mean I'm going to throw out the results of this study. Now, they looked at 66 pre-specified adverse outcomes across 15 organ systems, and there's no significant excess risk in 62 of those 66 pre-specified adverse outcomes. The 4 that were observed were an increase in liver enzymes, and this is why we monitor liver enzymes during treatment. It was a 0.09% absolute annual risk excess. So not a huge excess risk compared to what you see with placebo. There were other liver test abnormalities. That was 0.05% absolute annual risk excess. There was protein in the urine. That was 0.03 annual risk excess. And then edema, 0.07 annual risk excess. And in general, the risk is higher in high-intensity trials, and that was primarily driven by atorvastatin 80 milligrams, which is something that I never do. So, a lot to take home here. More designed for my healthcare professionals here in my audience. But I think it's very, very important for all of us to look at randomized controlled trials, look at what do we actually see in these trials. And the duration of the trials in this study was up to 4.5 years. So pretty good time period to see the adverse effects that are going to happen. And not just look at, well, post-marketing surveillance, which is important, but it is important to drill down what are we seeing in post-marketing surveillance versus what are we seeing in randomized controlled trials. And then do we need to do new randomized controlled trials, specifically looking at, are we people having this thing that we're seeing in post-marketing surveillance?